this is like the talk's around 30, 40 minutes and then
Yeah,
questions,
and then
right?
some Q&A. Yeah. So let's start. Good morning, everybody. Thank you for joining again this morning to our Monty Heartcast conference. It's great to have another friend again, a fellow Italian, Dominick Angiolil, who is from the University of Florida College of Medicine in Jacksonville. And to me, one of the leading experts really in antithrombotic therapy around PCI patients. And, so Dominick, I always learn so much from you, and you always give us a very practical approach of how to use the data. So we're really looking forward to this. Thank you.
Well, thank you, Azim, and thanks for the kind invite. Pleasure to be with you all. And a few months ago, when I received this invite, I looked at the program and I said, what are the things that I can speak about? And I've noticed most of the talks were surrounding a lot of things happening in the peri-PCI period. I decided to give a talk that affects all of us, which is more on the long-term antithrombotic approach of our patients with coronary disease. And when I speak about long-term, really the decision what to do once patients have completed their minimum duration of dual antiplatelet therapy. And I am very practical, and so I will also give a practical approach. And to be practical, I'll start off with a clinical case. So you're seeing a 62-year-old white female in your outpatient clinic. The patient recently relocated to New York after living most of her life in Florida. And she brings with her medical records from her last hospitalization, and you can see her medical history could be summarized as follows. She has a number of cardiovascular risk factors. She's diabetic. She has hypertension. She's an obese female, and she has some chronic kidney disease. Now, from a medical standpoint, she reports having a stroke 3 years ago, which is also when she was diagnosed with diabetes. She has some residual left-sided weakness from which she mostly recovered. She also reports at the time she started treatment with atorvastatin. And approximately 12 months ago, she experienced a non-STEMI and underwent PCI of the mid-RCA. She has a stent card, which she shows to you, and she was treated with a 3.5 by 18 millimeter stent. Her records also indicate that she has an intermediate stenosis in the mid-LAD, and she underwent an FFR, and it was suggestive of a non-hemodynamically significant stenosis. And she has been on dual antiplatelet therapy with aspirin and ticagrelor 90 milligram BID. So overall, patient that we see every day in our clinical practice, right? We have a mid 60-year-old female with a number of cardiovascular risk factors. She had a stroke, she had a non-STEMI, and she's treated with guideline recommended therapy. Now, since her non-STEMI, she has been mostly asymptomatic for angina. She complains of some atypical chest pain. She also reports occasional fatigue and shortness of breath, which she attributes to her deconditioning and obese status. Her ejection fraction at discharge was 45 to 50%. This was found, however, to be increased to 55% at a follow-up echo 6 months after non-STEMI. At that time, she underwent a stress test, which was negative for signs and symptoms of ischemia. A patient had an intermediate stenosis. I think it's reasonable to perform some type of non-invasive testing. Now, this is a patient who followed up regularly with a cardiologist in Florida. And this cardiologist strongly recommended that she establish herself with a new cardiologist once she got to New York. And it was very, very important that at 1 year, which is now, that a decision be made with regards to her blood thinning medications. Do we continue? Do we stop? Which one? And just to keep in mind, this is a patient who has a CBC, which is within normal limits. She has some chronic kidney disease. Hemoglobin A1C is well under control with being on metformin, and her LDL is at target. So the key question that pops up is, which antithrombotic regimen do we choose at this point in this patient? Do we say, like we used to do in the past, you're at 1 year, stop your ticagrelor, maintain aspirin? Or do we tell her to maintain dual therapy? But the important question here is which one? Okay, and we'll get to this in my presentation. There may be some concepts that for some of you may be new. So these are the guidelines, and here you see a summary of the ACS, and the stable guidelines, both from the ESC and from the ACCHA. We're going to be focusing on patients with an acute coronary syndrome, and you can see that the guidelines very consistently say that patients should be on 12 months of dual antiplatelet therapy if they do not have risk factors for high bleeding risk. Okay, this is a concept that you're going to be hearing a lot about, HBR, high bleeding risk. I'm not going to be speaking about high bleeding risk in the first year. Okay, I know that you probably had other talks on this. We're going to be speaking more about this concept a little bit, how it has an impact long term. Now, already at the time, the guidelines provided some suggestions, but these were overall very, very weak to prolong dual antiplatelet therapy. And this has led to a lot of confusion, right? Because the past 3, 4, 5 years, there have been a number of trials supporting that you can keep your dual antiplatelet therapy short and not pay the risk of stent thrombosis, right? We just have most recently trials that's saying that you can go to 1 month dual antiplatelet therapy, right? We have better stents. So why continue? That's the big question. And there's a lot of confusion in the interventional community, creates a lot of confusion also with trainees. So why and whom do we prolong dual antithrombotic therapy? And this is where we need to stop and think. What is it that we're treating? Right? And we are interventional cardiologists, but we're also doctors, right? And we need to distinguish between whether we're treating the stent versus the patient. Now, here I wrote the term vulnerable stent. In reality, there's no such thing of a vulnerable stent nowadays, at least with the commercially available stents that we have nowadays. They're all really, really good in my opinion, but things have never been better. I would like to focus your attention on the patient. And here I put a number, 20-25% risk of falling again in the next 5 years. And I'm going to explain to you what that actually means. Now, when they say a figure is worth more than 1,000 words, this is what I mean by it. We know that atherosclerotic disease is a systemic disease. And as good as we are in the lab and treating this with a stent, you can see that the arterial vasculature is far more diffuse than that very small segment that we are treating. And this is the reason why we use systemic therapies. We treat the disease. We're not treating the stent. We can prevent stent thrombosis, but fundamentally we are treating the disease. Now, we've learned a lot about this concept over a decade ago from the REACH trial. REACH is one of the major registries. We learned from the registry that, yes, patients who had a major ischemic event within the past years are those at highest risk of having another event. But we also learned that the patient who had an event more than 1 year ago still remains at risk. Okay. This is a concept which is called residual risk. And you're going to hear this term over and over and over again, because it's something that doesn't apply just to antithrombotic therapies. It applies to all type of secondary prevention medications. Here you see another registry. This is one of the ones that I like most, which is the Apollo registry. Apollo was a registry, a global registry, where they took patients who had an MI, and they were on guideline recommended therapy, and they were fine during the first year, just like Our Lady, right? She's on guideline recommended therapy, had no events, and the question comes up, what is her risk of having another event of the next 3 years, right? And you can see here across registries, maybe you're a little bit lucky if you live in France, but for the most part, you see that that risk over the next 3 years is around 20%. This is a very, very interesting concept. I'm sure that every single one of you, when you're in your clinic and you're seeing your patient in follow-up, right? The patient comes to your office for their 1-year follow-up. The classical question is, hey, doc, what's my risk of having another major cardiovascular event? Now, I give the same lecture to my fellows and I ask them the question, I get them as most bizarre answers, right? The most bizarre. We need to know, right? Because we need to inform the patients. And I just give a very simple response. In clinical trials, that risk is more or less 3% per year. But clinical trials do not represent real world practice. In registries, that's around 5 to 6% per year, which is what you're seeing right here, right? And it never plateaus. It just never plateaus. And so this has led to a new concept out there and new definitions, which is that of chronic coronary syndrome, CCS. This is a term that came from the European Society of Cardiology, not yet that much adopted in the United States. It's just a matter of time. And I think it's a perfect term, chronic coronary syndrome. Why the term chronic? Because as you can see from this cartoon, this is a chronic disease. Patients remain at risk for future events. And when you look at the curves, it never plateaus. Coronary, because it's a coronary disease. Syndrome, because it's a clustering of signs and symptoms that persist over time. Okay. So when we look at this cartoon, we have a patient who may have experienced an ACS. And according to the control of their risk factors, may be at increased risk of another event down the road or not. Okay, but nevertheless, you see these curves never plateau. So when you have less control of risk factors, or maybe you just have bad genes or bad luck, you can see that you have recurrent events over time, never plateaus, versus a patient who may be luckier or have better control of their risk factors. The likelihood of this happening is lower, but again, never plateaus. Now, why do we want to reduce the risk of an ischemic recurrence? Very simple. We want our patients to live, right? If you have a recurrent event and survive it, right? That's the other component. You got to survive your event. Your likelihood of surviving long-term, however, is a lot lower compared to the patient who did not have a recurrent event. So very, very important concepts. And this is the reason why we speak about residual risk. And this is the reason why we need to tackle this residual risk. We've done a lot of work over the past 2 decades of treating the patient within the first year, right? All these trials in ACS. Okay, now that they survived their ACS, we need to think about what to do for these patients for the next 10, 20 years of their lives. And this is the reason why we introduced the concept of chronic coronary syndrome. And it's a very broad definition, right? Here you see all the different scenarios of a chronic coronary syndrome. In our clinical practice as interventionists, we mostly focus on the patient who is stabilized after having an acute coronary event within, for example, the first year, or the patient after the first year. So I'm going to introduce to you now the new guidelines, or relatively new guidelines, because they're a year old, on patients with chronic coronary syndrome. And I would also like to say that these recommendations are identical to the most recent non-STEMI guidelines, also coming from the ESC, just reported a few months ago. I know the audience is probably saying, well, this guy's speaking about the European guidelines. We're in the United States. I know. We just don't have any update in the United States. Guideline updates in the United States typically take a lot longer. And it is for this reason that many practitioners in the United States do refer to the European guidelines, because they're more updated. Some people like the colors, and they are very practical. Okay. So I would like you to focus your attention on these recommendations. The recommendations do indicate that in a patient with a chronic coronary syndrome, just like our patient, without high bleeding risk, who are at high ischemic risk, have a class 2A level of evidence A to continue with a dual antithrombotic approach. Okay. Class 2AA, that is a very, very high recommendation. Essentially, if we translate into the wording of the ACC/AHA guidelines, it's what we define as a reasonable approach to consider, where the majority of the data indicate that the benefit outweighs the risk. It's 2AA. Okay. You may say, well, why isn't it 1? Very simple, because we know that there is a risk, which is bleeding. Okay. So very, very strong recommendation. This is a class 2B, if the patient is at moderate ischemic risk. And here you see all the definitions, and don't worry, you don't need to memorize them. I'm going to walk you through this in a very practical way. So the first question that we always need to ask is the patient at high risk for bleeding? Very simple. Yes or no? Now, within the first year, and you probably have had this talk in the past, we could refer to the ARC HBR definitions. It's very, very simple. You have an app. We don't have still yet a lot of information on the long term, the very long term. So we typically refer to the standard risk factors for bleeding. Okay, did the patient have a prior bleed? Does the patient have cancer? Does the patient have liver failure? Is the patient on dialysis? Is the patient particularly old? And so obviously, if a patient's high risk for bleeding, you're not going to continue. It's a very simple answer. Now, bleeding is very important. This is not a talk on bleeding, but I always like to highlight this slide on why bleeding is important and what are the mechanisms associated between bleeding and poor outcomes, which is essentially mortality. 1, a bleeding can be fatal. 2, bleeding leads to volume depletion and therefore hypotension, ischemia, and arrhythmias. There are complications from procedures to manage bleeding. When patients have a bleed, they discontinue life-saving medications, not just antiplatelets. For whatever reason, patients stop beta blockers, statins. Okay. Patients who bleed may get blood transfusions, and blood transfusions aren't good. The last but not least is maybe the least scientific, but the most practical, at least from my standpoint. We know that there are a number of unmeasured confounders because we know that sick people bleed and sick people die. So we really don't want these patients to bleed. So having said that, a very simple response, and a patient with high bleeding risk, what do? Well, we essentially keep our patients on aspirin monotherapy. Now, what if the patient does not have high risk factors for bleeding? So the question is, what's the ischemic risk? Now, there's a very, very simple rule to define ischemic risk. And again, I would like to highlight that there aren't any calculators here. It's not a quantitative approach. It's more of a qualitative approach. I like the qualitative approach. It makes us feel like doctors, right? You're not on your phone coming up with some calculations. So the rule is the following. The first question is, does the patient have multivessel coronary disease? Yes or no? And then the next question is, does the patient have enrichment factors? What are these enrichment factors? Diabetes, recurrent MI, PAD, and chronic kidney disease. So it's very simple. So if the answer is yes to the first question, multivessel CAD, and then the enrichment factors, this automatically is a high risk criteria. And our patient has this, right? The patient has multivessel CAD. She got 1 stent, but the patient also has an intermediate lesion in the LAD. That counts. Okay, the patient has diabetes, and the patient has a CKD. Now, if you have only one of these components, well, then the patient's considered moderate risk. So very, very simple. So the question at this point is, the guidelines, as I mentioned before, indicates maintain dual antithrombotic therapy. And these are the approaches that the guidelines recommend. You can consider clopidogrel. You can consider prasugrel. You can consider rivaroxaban at a vascular dose, and we're going to get to that. Or you can consider ticagrelor at a low dose. I'm going to walk you through these options and the reasons why you should versus should not be considering them, because these are decisions that you're going to have to be making in your clinical practice. The problem with gaining the information on which is the best option is the following. The guidelines, the European guidelines, both the CCS and the non-STEMI, just tell us what are the options. They don't tell us, however, how to choose within those options. I think that was a little bit naive from the guidelines, but they also did not want to be too pushy with the recommendations. What I can say is that at this point, there are some thoughts about performing some type of update on which treatment should be used and what's the level of evidence. Now, I just want to say I did see a question that did come in. I will address all questions at the end of my talk. So let's walk through the different options and try to define which is the best one for our patient. Now, I'm going to start off with the things that we should not be doing. Is Prasugrel, for example, an option in this patient? The answer is absolutely not, right? Because this patient has a prior ischemic stroke and there's a contraindication for Prasugrel. I do get the question, however, that why did the guidelines put Prasugrel in there, right? When you say, well, I just don't know of any long-term study with Prasugrel. And the two reasons, actually, the explanation comes from two reasons. One, in the DAPT trial, which I'm going to speak about in a few seconds, there was a small cohort of patients with Prasugrel, and formerly the DAPT trial was a positive trial. And the second reason, which was actually one of the main reasons, the guideline writing committee felt that Prasugrel is no different than any other P2Y12 inhibitor, and so why discard it, okay? But I would agree with the fact that it is the treatment with least evidence for prolonged treatment. So let's go with clopidogrel. Now, clopidogrel is our workhorse drug, right? I go to McDonald's across the street. I think half of the people in there eating a burger is on Plavix, right? And the reason is because it's generic. Physicians feel very comfortable with it, and we have some data, but it's probably not the best data. Let's keep in mind that the data to support prolonged clopidogrel post-MI derives from a subgroup analysis of the DAPT trial. And we also know that clopidogrel may not be that efficacious in certain patient populations, such as patients with diabetes or patients with CKD. I'd like to remind you of the DAPT trial. This was a trial which was mandated by the FDA to be conducted on behalf of makers of various stent platforms, which included also bare metal stents, because of the unmet need to address the question of what is the optimal duration of dual antiplatelet therapy because of the concerns of very late stent thrombosis with first generation drug-eluting stents. And what you can see is that patients who maintained a thienopyridine, again, the vast majority of these patients were clopidogrel, very few Prasugrel, did have a benefit. This was after 1 year. Again, these were patients who did not experience an ischemic or bleeding event within the first year. So again, it's a selected population. What was interesting that in the placebo arm, those who withdrew a P2Y12 inhibitor had an immediate increase in events. And those in the thienopyridine arm, when they stopped the thienopyridine at month 30, also had an increase of events. So clearly there is a treatment effect. But one of the most important analysis from the trial was, my opinion, this analysis on the ACS cohort from Barbier published in JACC, showing that there was an interaction between ACS and non-ACS presentation. What we do know is that there's an increased risk of bleeding. So when you look at the overall trial, a simple way of putting it, you have a 1% reduction in ischemic events, a 1% increase in major bleeding, so it almost becomes a wash, okay? So you need to look at populations that may benefit more. And clearly the ACS patients, where you see around a 30% absolute reduction in events and still that 1% increase in bleeding, this is where there is a greater benefit. And that's the reason why the guidelines made the decision that they made with regards to their upgraded indications. Now, again, this is a subgroup. Then we have the DAPT score and all these wonderful things. The other thing to keep in mind is a lot of the data when it comes to long-term clopidogrel in diabetics and patients, particularly those also with CKD, have shown the drug not to be as effective. And the main reason is due to the fact that clopidogrel, being a prodrug, needs to be metabolized, And one of the things that we've learned in patients with diabetes, their metabolism of the drug is significantly lower, significantly lower. So if you take a drug which by definition is less potent and it's less metabolized, there's very minimal added antiplatelet effects. So let's move on to the next option, which is ticagrelor, and particularly the 60 milligram. This is based on the Pegasus trial. I read over here possibly not necessarily the best evidence-based option. And as out of full disclosure, I would use this drug in this patient, but I say possibly not the best evidence-based option because one thing which is not well known about the Pegasus trial and which does not appear anywhere in the label is that in the patients in the Pegasus trial excluded patients who had a prior cerebrovascular event, something which is not that well known. But if you look into, for those of you who are involved with the trial, probably know after enrollment of the first 400 patients, the executive steering committee decided to not enroll any more patients with a prior stroke. Reason, if you may recall, at the time, there was a clinical trial development of other antithrombotics. One was Vorapaxar, where there was harm in these patients, right, with prior stroke. And so the decision was, let's not include these patients. Let's play safe. Nevertheless, it's a drug that's out there. We've become very familiar with it. And I think it's a very, very good drug for patients with coronary disease. So yes, it is an option, but maybe not the best evidence-based option. Here you see the results of the Pegasus trial. Again, these are all patients with a prior MI. And what you can see is what I mentioned before. These are all patients in a relatively modern era on standard of care therapies. And you look at the placebo arm, and again, these are all on the background of aspirin therapy. You see the event rate never plateaus, okay? We have this 3% event rate per year, as I had mentioned before, but it never plateaus. Can you modify that risk with more aggressive antithrombotic therapy? In this case, antiplatelet therapy? The answer is yes. The FDA wanted 2 doses, the 90 to 60 milligram, with ultimately no difference in ischemic events, but overall more favorable safety profile with the 60 milligram. Obviously, there was a price to pay, which was the increased risk of bleeding complications. But as you can see here, there were no differences in what we now call the irreversible bleeds. Which are the irreversible bleeds? The bleeds that you die from, so the fatal bleeds, or the bleeds that you wish the patient never had, which are the intracranial hemorrhages. Okay, so rates that are very, very low and no differences between placebo. And also with the 60 milligram, there was less dyspnea. So the FDA almost immediately approved this dosing regimen after 1 year. We have the last of the options, which most folks are not that familiar with, which is using rivaroxaban 2.5 milligram BID. This is what we call DPI, which is not DAPT, it's DPI. And if you listen during my talk, the whole time I spoke about dual antithrombotic regimen. I didn't speak about dual antiplatelet regimen because there are 2 dual antithrombotic regimens. One is DAPT and one is DPI, okay? And this is a very reasonable option for this patient because this is a COMPASS-like patient. And I'm going to explain to you what this means. And I'll go a little bit slowly on this concept because I understand it's a very new concept. And I can say that when I'm speaking about this with my colleagues or my fellows, many of them are still not that familiar with the concept of dual pathway inhibition. And the reason is, and I'm as guilty as anyone, that for the past several decades, we've been speaking about the role of antiplatelets to prevent arterial thrombotic events, and that anticoagulants are useless for this. And the truth is that the COMPASS trial shows us differently. So why is this concept introduced, dual pathway inhibition, and why do we call it dual pathway inhibition? Well, we know the vast majority of our patients out there with stable coronary disease or with PAD, although we should not be calling them stable CAD, we should be calling them CCS, are on aspirin. And we know, because I showed you all the data, that they remain at risk for ischemic recurrences. So what does that mean? It means that aspirin is not enough, right? This is what we call treatment failure, not to confuse with resistance, okay? Treatment failure. And we've learned that there are a number of studies adding a second antiplatelet, take Charisma, for example, or other studies, that have not been so successful. So the question becomes, can we consider a different target? And that different target is a low dose rivaroxaban. It's what we call vascular protection dose. Very different from the AFib dose. Again, I'm not speaking about AFib. It's a very different dose, and there's a very different reason for giving that dose. And you cannot extrapolate dosing regimens from other NOACs to the vascular protection dose with rivaroxaban. So the reason why we call it dual pathway inhibition is what you see in this cartoon. I'm going to make it very simple. We have two main pathways leading to development of a clot: coagulation and cellular platelets. Okay, so the cellular is simple. We've been dealing with this for decades, right? You use aspirin and you block platelets. When you use an anticoagulant, okay, let's say an anti-10, you block downstream thrombin. Thrombin is the main inducer of platelet activation. So what happens is you block coagulation, but you have an indirect on platelets. And you have synergism by using the two drugs. What does synergism mean? Synergism is different from additive effect. Additive effect is 1 + 1 is 2, right? That's additive. Synergism is 1 + 1 is 3, okay? So the thought process, can we take this concept and now apply it to patients with coronary artery disease? This has been tested in ACS. The problem with ACS is that most of the studies were done on top of clopidogrel when the standard of care is prasugrel or ticagrelor. It was done with a large number of NOACs, but only one succeeded. One reached the end. For those of you who've watched Highlander, right? Only one will remain. Okay, in Italian say ne rimarrà uno solo, right? Only one will remain. Okay, and that was, out of all the trials that were out there, was with the vascular dose of rivaroxaban. However, that was, although implemented in guidelines, it really never took place because of new agents. So the next question was, can we apply this concept in patients who are more stabilized after 1 year from their event, and patients who are just on aspirin alone? And this is the rationale for the COMPASS trial. And here you can see a very large trial with patients with PAD and CAD, patients randomized to be on aspirin alone, standard of care. They evaluated the rivaroxaban 5 mg twice daily without aspirin, and then the DPI dosing regimen, which you see here, rivaroxaban 2.5 BID plus aspirin. And here you can see the outcomes of the trial, where the DPI arm achieved a 24% relative risk reduction in ischemic events compared to aspirin alone. Now, I've been doing clinical trials for many years, and in the past 2 decades, I'm aware of only 2 trials in the cardiovascular field that were interrupted prematurely for overwhelming benefit. Okay, and this is one of them. The other one was a statin trial. And typically, a trial can be interrupted for one of three reasons: harm, right? That's not a good thing. Futility, in other words, you can continue for the next couple of decades, you're never going to see a benefit. Or 3, overwhelming benefit, which is very rare. And typically, when a trial's blocked for interrupted for overwhelming benefit, is because there's a mortality signal. Okay, and this is what was observed in the trial. There was a reduction in cardiovascular death. There was nearly a 50% reduction in stroke, and there was a numerical reduction in MI. Okay, this is again for the DPI dose. With the rivaroxaban alone, there was no benefit. So very important data. There were consistency in the findings between patients with CAD and PAD, and this is very important because for the first time ever, we have a drug being used in patients with PAD that reduces MACE, okay, major adverse cardiac events, cardiovascular death, MI, stroke, and MALE. This is a new terminology, major adverse limb events, which essentially is severe limb ischemia leading to an intervention or an amputation. No other drug has done this. None. We've tested additive effects of a P2Y12 inhibitor, no benefit. We've looked at drugs such as Vorapaxar. Okay, there's a reduction in MALE, but there was not a reduction in MACE. And plus, I don't know if anybody uses Vorapaxar. It's essentially non-existent. So many strategies, but this was the only one that worked. This data was replicated in patients undergoing revascularization in the Voyager PAD, just presented recently and published in the New England Journal of Medicine. And so again, consistency in the finding. Now, is there a price to pay? Yes, there's no free lunch. Just like we saw with the Pegasus trial, there's an increased risk of bleeding, but there was not an increase in the fatal or non-fatal intracranial. But when we look at the net benefit, this still favored the DPI strategy. I am going to now conclude with this slide, and happy to entertain any questions just on time. Is an algorithm that we put together with a number of key opinion leaders from the United States and Europe on how to manage the patient who walks into your clinic and you need to make a decision, right, on what do you do. And we typically have two scenarios, right? You have the patient who is like our patient 1 year after MI, and they're completing the dual antiplatelet therapy. Or you just have the random patient who walks into your clinic who has known chronic coronary syndrome and is on single antiplatelet therapy, right? Patient walks into your clinic and you need to make a decision. So first question, is the patient high risk for bleeding? Yes or no? The answer is yes. It's very simple. You continue with single antiplatelet therapy. Most data would support the use of aspirin monotherapy. Now, having said that, you can also consider P2Y12 inhibitor monotherapy, although there's less data to support this. Something that's being used a little bit more in Asian countries. So if the answer is no, the patient is not at high risk of bleeding, we ask our question, is the patient at high risk for ischemic events? And we go back to those questions that we said before. Does the patient have multivessel disease? And are there enrichment factors, right? Diabetes, PAD, recurrent MI, CKD. You can also throw in heart failure in there. There's a lot of mixed feelings about heart failure. Should it be in there? Should it not be in there? I look at the overall patient, right? And you make a decision. It's not like heart failure is the deal breaker. So if the answer is no, the patient is not a high ischemic risk, well, you're done, right? Patient continues with single antiplatelet therapy, typically aspirin. If the answer is yes, I think a key point that we need to keep in mind is whether the patient had a prior ischemic stroke or not. The reason why I say this is because if the answer is yes, the only long-term trial that fully evaluated safety of a prolonged dual antithrombotic regimen in patient also with a prior ischemic stroke was the COMPASS trial. Okay, and in this specific patient, the answer is pretty simple, right? You go with a DPI strategy. This is important, right? I'm sure you guys have in your clinic these vasculopaths that walk into your clinic. They have coronary disease, they got peripheral vascular disease. Patient may have had a couple of strokes, right? So you need to make that decision. If the answer is no, then we ask our question, did the patient have a prior MI? And here you can go with either strategy. You can go with DAPT, where my personal opinion, the best evidence is with the 60 milligram of ticagrelor, or you can go with a DPI. We can speak about later which one do you choose and how do you choose. And if the answer is also no, and the patient did not have a prior MI, you can consider a DPI a DPI strategy. Although most recently, we did not know this at the time of writing this, the FDA also approved, based on the Themis trial, the use of ticagrelor 60 milligram for patients without a prior cerebrovascular event or acute coronary event. So this is overall a very simple algorithm that you can use in your clinical practice. I've showed you the data. I showed you the event rates. I do believe, which is critical, and this is something that particularly the ACCHA guidelines do put a lot of emphasis on, is the concept of shared decision making. You need to be able to speak to the patient, explain the risks, explain the benefits, and come up with a decision. I know that patients many times tell you, well, you're the doc, you tell me what to do, you tell me what's best. But I do believe in a modern era, you have to have this shared decision making, which needs to be fully documented, and then evaluate these patients on an annual basis and decide whether treatment should be continued or not. Having said that, I finished just on time and happy to entertain any questions. Thank you very much for your attention.
Dominick, thank you so much. That was really a phenomenal talk. And I guess, as always, I learned so much. And I realized that probably, like many of us, we overlook this important issue. I mean, having been in Europe when the whole concept of chronic coronary syndromes became coined, I must admit, not all of us as interventionists jumped on this new terminology, probably because I guess we maybe didn't understand how it was going to change our practice and how we should be using it. But I think today's talk really does help a lot with having me myself rethink about how I think about my patients long term. I'm going to have one of our fellows, Shun, join us as well. We like to have a fellow really post some of the questions that fellows have, and then we'll address any questions that people have and they want to put in through the chat or QA.
Thank you for a very important talk. I'll be honest that I actually have not heard of the concept of chronic coronary syndrome, the CCS, myself, and also the DPI. I knew the concept, but I didn't know there was a terminology for that. All this long-term regimen to minimize the risk for the patient is very important, but I'll be honest, I've been guilty of not thinking that far in long term. So this was a very important talk, so thank you very much. I have a question myself. What would be the best timing, especially for all these short DAPT trials coming in? Like within a year, I think there's more and more data saying for high bleeding risk, shorter is probably better. What is the best timing to rethink about? I guess for high bleeding risk, it's the same question, same answer, but is 1 year the best timing to rethink about what's the best regimen for these patients?
Yeah, great question. Well, I'll first address the first part of your comment about not being that familiar with certain terminology, and that's okay, right? that is okay. That's the reason why you have these lectures. And I also understand that we're in a period where the past 6 to 9 months we've been where we have COVID fatigue, and that we tend to speak mostly about COVID. You pick up a journal, it's all about COVID. So that's justifiable. Let's put it this way. But moving forward, COVID is going to go away, and we're going to have to take care of these patients. So happy to give a refresher on this topic after COVID. Now, to answer the question, the concept of HBR, I think HBR is just the way ischemic risk is dynamic, right? I do believe that your first decision-making process is actually in the cath lab. And you need to know your patients and decide your P2Y12 inhibitor, and definitely make a decision when you're discharging the patient. I believe that not because I'm part of the ARC HBR working group, but I really believe that This is an excellent tool. And when we're looking at all the data that's being published now to validate ARC-HBR, they're supportive, okay? So I think your decision making is already there. So then the question becomes, which of the bleeding reduction strategies can we consider? Now, when Dr. Lateeb invited me to give this talk, I was debating whether to give the talk on bleeding reduction strategies or to give this talk. I decided to give this talk, but the bleeding reduction strategies are fundamentally three. One is short DAPT, two, stopping aspirin, and three, de-escalation. I cannot tell you which is the best one because we don't have head-to-head comparison. Every patient is different. I can tell you, however, that the aspirin-free approach, or short DAPT and continue with P2Y12 inhibitor, has received a lot of attention. It's now within the guidelines, the European guidelines, with a class 2A, which is pretty substantial. And I'm a strong believer in it. And let me tell you why. I'm sorry if I'm making this so long, but I'm a fan of antithrombotics. Aspirin, there's a problem with aspirin, which aspirin is a toxic drug, okay? There's gastrointestinal toxicity. And we know that P2Y12 signaling is key in platelet amplification processes. So I know that P2Y12 provides a lot of protection while having that GI toxicity. So this is a strategy that I strongly endorse, and again, not because I'm part of the Twilight trial, but because I believe in P2Y12 inhibition. Having said that, short DAPT is easy to understand, all right? Stop the P2Y12 inhibitor and continue with aspirin, because this is a downstream effect, and I'm sure that the experienced clinicians in the room experience what I've experienced sometimes. You tell them to stop the aspirin, right? You write it in your note, and then these patients go to the primary care doctor and says, who told you to stop aspirin? Continue to take it, just don't tell your cardiologist that I told you, right? And since it's over the counter, and then these patients come in with a bleed, right? And so that's my main challenge. So you got to do something which the patient will understand.
So
hopefully I answer that question.
So what is your approach? What do you do? I mean, because I always love to hear what people, there's the guidelines, and what do you do in your practice?
Yeah.
I mean,
so with my older patients, I'm going with the traditional short DAPT. The traditional short DAPT keeps it easy. It just keeps it easy, right? Also, because what happens a lot in your older patients, they're going to require some type of surgery. They come into the office, hey, Dr. A, I need a cardiac clearance. And then they may be on a P2Y12 inhibitor. You got to switch them to aspirin because they have a stent. It's just like a mess, right? So I just keep it simple. Aspirin, done. My younger patients, I'm starting to stop aspirin as a bleeding reduction strategy, but not necessarily because they are high bleeding risk. Remember, Twilight, they were also very high ischemic risk, and there was a huge advantage. And these patients will take a P2Y12 inhibitor. They're not complaining about the gastric stuff. There's less bleeding, and I believe that it provides more protection. So that's what I've been doing.
So
but again, it's personal.
You've been stopping and continuing ticagrelor, right?
Yeah, 3 months, 3 to 6 months.
I mean, but potentially that could also be another strategy for chronic coronary syndromes, right? It's just long-term ticagrelor, right?
So I wish we would have done Twilight a little bit sooner, and I also wish that one of the makers of antiplatelet therapies had a little bit more money, because that's the missing study, right? And at the time of Pegasus, we thought about doing it. The FDA, there was like no way on planet Earth that the FDA would have allowed us to have a P2Y12 inhibitor monotherapy. That would have been the trial, right? We had an opportunity. We had a great opportunity. It would mean a fourth arm. Do I think that's reasonable? I do. We're going to be starting a pharmacodynamic study. Unfortunately, it's pharmacodynamic, not clinical, addressing this exact question that you answered, right? Afterwards, chronic coronary syndrome, take away aspirin. There are 2 studies actually going on in Asia. One is the host exam, and the other one is the by-risk study looking at a P2Y12 inhibitor monotherapy after 1 year. Problem with some of the studies conducted in Asia, it's not the good quality, is that can you translate them into Western practice? There's always a little bit of hesitance. Having said that, hopefully we'll be able to do this, but that's the missing study. I'd love to have that. The other thing that we're working on, which is a parallel topic we did not speak about, is how can we come up with better aspirin formulations? Right? It's not like that aspirin doesn't work. Aspirin does work. It's just toxic, and there are problems with absorption. So can you come up with a formulation that you absorb better, works better, and not that toxic? So there is a lipid based compound aspirin formulation developed by PLX Pharma, and so we've been working on its FDA approval. So there'll be a launch of the drug soon, but it's in the 325, not yet on the 81 milligram, which shows all these wonderful things because it's a capsule base. You can take it with food without any issues. Because another problem that happens with aspirin, we tell our patients, "Oh, doc, I got some stomach burn when I take aspirin." Well, take it on a full stomach. That's the last way you want to take aspirin, because then you don't absorb it. So we're 60 to 70% of practitioners across the globe are telling their patients how to take aspirin with food, which is the way we should not be taking it or prescribing it. And I'm as guilty as many others, because I would tell my patients about this in the past. I started studying a little bit more aspirin. When I say studying, like really studying aspirin over the past 5-6 years. And you learn so much about a drug that's been out there for so many years and how so many of us know very little about it.
Haven't we all done that? Absolutely. Shun, go ahead. Thank you.
Yeah, I have one quick question and I'll move on to the chat. On the Twilight, after 1 year, I know the methods in the New England Journal says was switched to standard care antiplatelet. Was it all aspirin? Like after monotherapy with ticagrelor, did they switch to aspirin, or did they continue?
Yeah, so that data is not in the public domain, and so I cannot fully answer it. I would anticipate that most people would keep put their patients back on aspirin, or some patients may put them on aspirin and clopidogrel. I see there are a few comments in the chat box I would like to quickly tackle, because I think they're really, really important, which is the dosing of the DPI and how we can apply this to other NOACs. So the short answer, other NOACs, no, you cannot. Okay, that's important, because Eliquis, apixaban, is largely utilized in AFib, and say, well, can I just use a 2.5 milligram of Eliquis? No, can't do that. Okay. That's already been tested in a trial, in the PRAISE trial, and this was, as we know, there was no benefit. There was a lot more bleeding, so the answer is no. Okay, the rationale behind the dose of rivaroxaban and DPI, I'll explain that, because that's another question, very important. So this is 1/4 of the AFib dose, 1/4. Okay, it has different effects. The reason why it's twice daily is, I don't want to get into too many details from a pharmacokinetic standpoint, but when you look at the 20 milligram PK, you have drug levels that covers almost the full 24 hours. Doesn't get there, but it's okay to give once daily. When you're giving the 2.5 milligram, you have a little hump. Okay, so you need 2 humps essentially to cover the 24 hours. That's the reason why it's BID. I understand it creates a lot of confusion, because the makers of rivaroxaban praise themselves. We have our drug once daily. Your elderly AFib patients are not going to get confused. And then they come up with it twice daily. Well, that was the right thing to do, because that's how the drug works. Okay, so it has to be twice daily. That's the rationale. There was a dose finding study to get to 2.5 milligram. This was not chosen randomly. Okay, there were a lot of studies before that. The largest phase 2 program ever with a NOAC. Okay, and you cannot use other NOACs. Okay. There's another comment about warfarin. DPI should not be hard to sell to older interventionists, as in the good old days. That's what we used. That is true. So for those of us in the room who have gray hair, who have no hair, I think I fall in that category. Okay. Prior to the introduction of mostly clopidogrel, because still at the time of ticlopidine, which is another drug that the younger folks in this room probably don't even know what it is. Yeah, warfarin was used, and it worked. It reduced MI. There's only one problem. I know I'm being recorded here, but warfarin sucks, right?
True.
It's a horrible drug. So that's an excellent comment. Any more questions?
There was one year about, you talked about long-term therapy. What does that mean? Lifelong?
Good question. So I always say that your ischemic and bleeding risk is dynamic. So I evaluate patients on an annual basis, right? Patients get older. So there's never anything which is lifelong. When we do these trials, we intend long-term, just like we would consider a statin, right? They're not lifelong trials, but we consider them lifelong. So what we have learned is that there's an initial phase, which is called like the bleeding stress test. I didn't show the slide, but if you're going to have a bleeding complication in these long-term therapies, it's typically going to happen early, and it's not going to happen after one year. And we see that the magnitude of benefit continues to increase over time, the net benefit. It's interesting, the curves just continue. So I evaluate these patients. For me, it makes a lot more sense when you have a patient who's young or relatively young to initiate this treatment and continue long-term for years, because that's where you're getting the benefit, versus an elderly patient. And you just evaluate over time. Nobody has 10 years data on this, right? So you evaluate on an annual basis. And this doesn't take away, however, other approaches such as the potential for anti-inflammatory approaches, very aggressive lipid lowering approaches. These are very, very important. And I don't know about your practice, Azim and Juan, but I'm seeing that half of the patients who come in with an acute coronary syndrome in my hospital are younger than me, and I don't consider myself that old. I mean, so, and you think about, these are individuals who still have, theoretically, 20 to 30 years at least of life ahead of them that you want them to complete. And so I think it's very, very important to be aggressive with their secondary prevention measures. And that's why I believe that the concept of chronic coronary syndrome is so important for individuals in this age range.
Yeah. There was a comment here from Manaf, maybe.
Right. Can you address any thoughts on enteric-coated aspirin?
I could speak for hours on enteric-coated aspirin, but I'm going to keep it brief. So let me give you a little bit of history, okay? I'll try to keep this within 120 seconds. So we've known for decades that aspirin is toxic on the GI mucosa. Therefore, there have been efforts to reduce such toxicity by providing a coating. This was originally developed with the higher doses of aspirin, which were used mostly for anti-inflammatory purposes. They were then extrapolated to 81 milligram of aspirin. What you find, go to pharmacy, safety aspirin, coated aspirin, all these wonderful things. Unfortunately, the data supporting safety are not there. Because when you look at all the endoscopy studies, and there's some relevant studies, they've shown that the enteric-coated simply does not prevent GI damage. And so it's almost, I hate to use the term fake news. Now we're change of but it's almost fake news. It's almost fake news. In fact, it's called safety coating. It's not called safe aspirin. there are all these things from an FDA perspective that people can play around with. So the problem with the enteric-coated, it is the #1 driver of impaired absorption. It's what we call pseudo-resistance. It's not that aspirin is not working, it's that the aspirin is not getting absorbed. And so, my opinion, and I've been saying this now for some time, a lot of the achieved benefits with adjunctive antithrombotic therapy is also derived from the fact that you're not getting your bang for your buck with aspirin because it's not achieving its full effects. I would love to see a big trial with a better aspirin formulation and how this has an impact on outcomes. It's really interesting, right? We're in 2020, and we're having all these debates surrounding aspirin.
Maybe one last question. A few years ago, there was a lot of interest and discussion in prophylactic use of PPIs in patients with DAPT and long-term DAPT. Quickly, your thoughts on that?
Yeah. So routine use, the answer is no. There really is no data. We have an analysis from the Compass trial that there was a 2x2 randomization looking at the PPI, and there was no benefit. So my recommendation is use it if patients are particularly high risk. So my elderly patients also on oral anticoagulation, for AFib, and also get PCI. That could be another topic that we can have in the future. Those who have a history of a GI bleed, but I would not recommend it routinely. I'm less concerned about the drug-drug interaction with clopidogrel. So I typically just recommend based on the need. There has to be a need, but not routine.
Okay, great. Dominick, thank you so much.
Great. Well, thank you.
The night you had. I hope your daughter feels well.
Thank you.
We miss seeing you in person.
Likewise.
And we look forward to seeing you in person again. And
see you guys.